Kanski lecture series, and this is going to be the glaucoma part 11. In this part we are going to discuss about the ghost cell glaucoma. So basically the ghost cells are basically whenever the patients encounter a vitreous hemorrhage, and the vitreous hemorrhage, the red blood cells from the vitreous hemorrhage crosses the vitreous and comes into the uh, anterior chamber, they and obstruct the trabecular meshwork, and they cause the glaucoma. So what is the pathogenesis? Ghost cell glaucoma is due to the trabecular obstruction by the degenerate erythrocyte, which cause the raised IOP. So these are the degenerated erythrocytes, and rarely glaucoma. Approximately 2 weeks after a vitreous hemorrhage, hemoglobin leaks from the erythrocyte, which evolves into the ghost cell. Very important. Basically, 2 weeks after the vitreous hemorrhage, it can occur the ghost cell glaucoma. So basically, the hemoglobin released from the erythrocyte RBC, and they evolve into the ghost cells. These then passes through the defect in the anterior hyaloid phase and pass into the anterior chamber. Because their pliability is lost, the cells become entrapped within the pores of the trabecular meshwork and obstruct the aqueous outflow. The condition may occur in the following settings: cataract surgery in the context of a pre existing vitreous hemorrhage in an already aphakic or pseudophakic eye. So they can occur in whenever there is a cataract surgery in when already there is a vitreous hemorrhage in the posterior segment, and if there is a vitreous hemorrhage in already aphakic or pseudophakic eye. When cataract surgery is complicated by a vitreous hemorrhage and hyphema, the hyphema clears but the red cells in the vitreous persist and evolve into ghost cells. Clinical features: the cornea may be edematous due to elevated IOP. The interior chamber exhibit ghost cell, which may be recognized as a reddish brown or haki particle in the aqueous. This should not be confused with the leukocyte, since this may result in an unwanted treatment for uveitis. So basically, in the AC, the ghost cells are like a reddish brown or haki particles, and in the AC. So, what is the treatment? Medical treatment with aqueous suppressant, irrigation of the interior chamber with washing out of the ghost cell if medical therapy fail. Pars plana vitrectomy may occasionally be required for persistent vitreous hemorrhage. Iridocorneal endothelial syndrome. So this is the conioscopy of the angle recession showing irregular widening of the ciliary body. So this is related to the angle recession glaucoma. So what is basically eyes? Introduction: iridocorneal endothelial syndrome typically affect one eye of a middle-aged woman. Very important because it is most commonly seen in a middle-aged woman with the only one eye, unilateral. It consists of the following three clinical presentation: Chandler syndrome, progressive, also termed as essential iris atrophy, and iris nevus. It's like a mnemonic is like eyes. So how it is eyes? That I is for that there is going to be the iris nevus, which is also known as a Cogan-Reese syndrome. Then C is for the Chandler syndrome, in which there is an iris atrophy, and E is the essential iris atrophy. The pathological basis in all the three is an abnormal corneal endothelial cell layer. So basically, sorry, the Chandler syndrome is associated with the corneal endothelial abnormalities. The pathological basis in all the three is an abnormal corneal endothelial cell layer with the predilection for proliferation and migration across the interior chamber angle and onto the surface of the iris, with subsequent progression to glaucoma 50%, and corneal decompensation in a substantial proportion of the involved eye. So basically what happened is that there is an abnormal endothelial layer that basically proliferate and migrate to the angle, and after the angle they progress to form the glaucoma and also cause the corneal decompensation. Glaucoma is due to trabecular obstruction by the proliferating tissue. So basically, there is a membrane that has been formed on over the angle, and it is causing the obstruction of the aqueous humor outflow. followed by the angle closure secondary to the contraction. Polymerase chain reaction testing shows that the presence of a herpes simplex virus DNA in a substantial percentage of eye syndrome corneal specimens suggests a possible viral etiology. So very important. So there can be possible viral etiology, especially with an HSV in eye syndrome. Diagnosis. Clear differentiation between the three presentation may be difficult. Apparent transition from one to another has been reported. Differentiations depend upon primarily on the iris appearance, but there is often substantial overlap. Gonioscopically visible changes in some patients may be subtle despite elevated IOP, particularly in early disease. The specular microscopic appearance is characteristic. Next is the Chandler syndrome. Chandler syndrome is the most common clinical presentation and is characterized by the abnormal corneal endothelial appearance said to resemble a hammered silver. So basically, in Chandler syndrome, the predominantly the cornea is becoming affected. And how does the cornea appear? Like a hammered silver appearance due to the abnormal corneal endothelium. It frequently presents with the blurred vision and halos due to corneal edema. Iris atrophy is absent in 60% and in remainder is variable in severity. So iris atrophy is usually absent, but in sometimes it is also present. Correctopia is mild to moderate when present. Correctopia is basically the pupil is abnormally shaped, is called correctopia. When glaucoma occur, it usually less severe than other in um, less severe than in other two presentations. Next is a progressive essential iris atrophy is characterized by the iris changes including correctopia. It is correctopia is basically the pupil is being malpositioned, the shape is being changed. Iris atrophy in the early stage, there is a pseudopolychoria. Pseudopolychoria means that there can be the multiple holes in the iris and causing the multiple pupil formation known as pseudopolychoria. There can be the one that is the patient real pupil and the other holes becoming the pseudo pupil. Next is supernumerary false pupil and broad based pass best peripheral anterior synecdoche that often extend interior to the Schwalbe line. Severe iris atrophy occur in the late stage and associated with ectropion uvei and severe glaucoma. Third is the iris nevus or Cogan-Reese syndrome is characterized by either a diffuse nevus that cover the interior iris or by the iris nodule. So basically iris nevus can be diffuse and localized. Iris atrophy is absent in 50% of the cases and in the remainder it is usually mild to moderate, although correctopia may be severe. The appearance may be mimicked by a diffuse iris melanoma. So this is a Chandler syndrome. A is showing the hammered silver endothelial changes. B is showing the corneal edema due to endothelial decomposition. 11.54 or iridocorneal endothelial syndrome. A is showing correctopia, so you can see the pupil is being malpositioned, is little bit of peaked. B is showing iris atrophy, you can see the multiple iris holes forming the pseudopolychoria. And C is showing the pseudopolychoria, that there is another hole and there is a one real hole, so it is making us polychoria. D is showing conioscopy, showing the broad peripheral synecdoche formation. E is showing progressive iris atrophy with pseudopolychoria. F is showing the transillumination of the eye in E. So, and 11.55 is showing the iris nodule in a Cogan-Reese syndrome. You can see the multiple nevus formation on the iris. Treatment. Medical treatment of glaucoma is usually ineffective. Trabeculectomy with mitomycin C can be tried, but the long-term results are poor. Basically, the medical treatment is ineffective. We always go for the surgical treatment in case of a eye syndrome. Glaucoma drainage device or cyclodiode laser may be required. Corneal treatment, edema can be treated with a topical hypertonic saline in early diseases and transplantation later on. Prognosis, the long-term prognosis is poor. Now there is a glaucoma that has been associated with the intraocular tumor. About approximately 5% of the eyes with the intraocular tumors develop a secondary elevation of IOP. Potential mechanism are set out below. So basically, there is a tumor in any part of the eye that is causing the glaucoma is known as glaucoma associated with intraocular tumor. So the possible mechanism is that one is the trabecular block and then there is a secondary angle closure. Distinction between the different mechanism may not be possible clinically. Angle invasion by solid iris melanoma, trabecular infiltration by neoplastic cells originating from the iris melanoma. So they can be angle can be invaded by the melanoma itself, and there can be the neoplastic cells obstructing the trabecular mesh. Lately, tumor seeding from the retinoblastoma may also invade the trabeculum. Melanomalectic glaucoma may occur in eyes may occur in some eyes with iris melanoma. It is due to trabecular blockage by macrophages that have ingested pigment and tumor cells similar to phacolytic glaucoma. Secondary angle closure glaucoma. Neovascular glaucoma is the most common mechanism in eyes with the choroidal melanoma or retinoblastoma. Interior displacement of the iris lens diaphragm may occur in an eyes with a ciliary body melanoma or a large tumor of the posterior segment. So basically, there is there is a tumor that is basically causing the rotation of the interior ciliary body and causing the obstruction of the angle. One is that it can also occur due to neovascular glaucoma, especially in choroidal melanoma or retinoblastoma. So this is a figure that has been 11.56 is showing the glaucoma secondary to the intraocular melanoma. Angle invasion by the solid iris melanoma. B is showing melanoma cells infiltrating the trabeculum. C is showing interior displacement of the iris by the ciliary body melanoma. Glaucoma secondary to epithelial ingrowth. So epithelial ingrowth introduction. Epithelial ingrowth or downgrowth is a rare but potentially blinding complication of the interior segment surgery or trauma. So after any kind of surgery or trauma, when there is a loose wound or the wounds has not been closed and there is a proliferation of the epithelium into the endothelium, it is known as epithelial ingrowth. Occurring when a conjunctival or corneal epithelial cells migrate through a wound or proliferate in the interior segment. Elevation of the IOP is due to trabecular obstruction by one or more of an epithelial membrane, secondary cynical angle closure, and a desquamated epithelial and inflammatory cells. The associated glaucoma can be particularly intractable and the prognosis poor. Diagnosis. Persistent post-operative anterior uveitis can occur in a case of epithelial ingrowth. So there will be uveitis. Diffuse epithelialization characterized by the grayish translucent membrane with the scalloped border that involves the posterior corneal surface in the area of surgical or traumatic wound. Cystic and fibrous proliferative pupils sometimes occur and tends to have a better prognosis. Pupillary distortion. Treatment. The aim of treatment is the eradication of all the invading epithelium to avoid recurrence. Block excision involves the simultaneous excision of the adjacent iris or pars plicata of the ciliary body, together with the all the layers of the sclera and cornea in contact with the lesion. The resultant effect is covered by the tectonic corneoscleral graph. The area of the iris involvement may be delineated by the applying argon laser burn, which will cause the whitening of the affected area. So you have to excise all the tissues of all the epithelial tissue. So you can excise the iris, placata, ciliary body, and you can also excise the adjacent cornea and sclera. And when you excise it, you will replace it by the donor corneoscleral graft. And iris involvement, you basically put the laser on the iris of the affected eye. Cryotherapy may be applied to devitalize the epithelium remaining on the posterior surface of the cornea in the angle on the ciliary body. Intraocular air is used to insulate other tissue from the effect of the cryotherapy. So you can use the cryotherapy to basically devitalize the epithelium. Intracranial 5-fluorouracil has been tried with a variable result. There is some evidence that intravitreal injection of methotrexate 400 mg per 0.1 ml every 2 weeks for 6 cycles can lead to successful resolution of ingrowth. So antimetabolites have also been used. Like you can use 5-fluorouracil, but like methotrexate is being used with a dose of 400 milligram per zero point 0.1 ml, and we give it every 2 weeks for 6 times, and it has led to the resolution of the ingrowth. Glaucoma drainage devices are of value for medically uncontrolled glaucoma associated with extensive epithelial ingrowth unsuitable for the surgical excision. Next is an iridoschesis. Iridoschesis is a rare condition typically affecting both eyes of an older patient. So it occurs in both patients. Primary angle closure and primary angle closure glaucoma is associated with up to 90%. The appearance may rarely occur after trauma. The mechanism is incompletely understood, but it has been proposed that intermittent substantial elevation of IOP result in iris atrophy with severity ranging from stromal atrophy to fibrillar disintegration of the interior layer. So basically, in a case, usually iridoschesis occur whenever there is an intermittent angle closure in a patient, and it causes the trauma to the iris. So there will be the um, stromal atrophy, and there will be the disintegration of the interior layer of the iris. Changes are more marked inferiorly, but often involve the but can involve the superior iris. The pupil is usually normal and the interior chamber is typically shallow. Gonioscopy commonly show an occludable angle, often with peripheral interior synergy. So there is an occludable angle in the iridoschesis. Angle closure should be treated with laser iridotomy. So basically, it occurs in a older patients, and it typically is bilateral. So that's it for the glaucoma part 11. See you in the next lecture.